everyone, and welcome to another episode of MidSynapse podcast. I am Hetvi Shah, your host, and today we have the distinct honor of speaking with Dr. Amitav Banerjee, a renowned expert in epidemiology and public health. It gives me immense pleasure to introduce Dr. Banerjee today as he has an illustrious career spanning over 4 decades. Beginning with his service in the Indian Armed Forces, where he earned numerous accolades for his work in epidemiology. Currently, he is the head of the Department of Community Medicine at Dr. D.Y. Patil Medical College and editor-in-chief of its medical journal. He is a sought-after reviewer globally and has contributed significantly to public health literature, including writing expert columns for the National Herald. And in this episode, we'll discuss the crucial topic of how to prepare for the next pandemic. Especially with the lessons from COVID-19 still fresh in our minds, it is imperative that we enhance our preparedness for the future challenges. So, Dr. Banerjee, welcome to the podcast, and we are so thrilled to have you today.
Thank you, Hetvi, and it's a pleasure to come on the MedSynapse platform.
Same here, Doctor. So, before we dive into our main topic, I would love to start a bit about your professional journey, as we know that you have had a remarkable career in both military and civilian medical fields. So, could you share some highlights of your journey and any memorable experience that you have that have shaped your approach to public health?
Yeah, it's a long way actually. I just did my graduation from Jabalpur. Then I worked for some time in anesthesia, then joined the armed forces. Couple of years worked in anesthesia, then I switched over to public care. Then I worked as a general duty medical officer. And then from AFMC, I specialized in public health, in community medicine in 85. And then worked as a public health specialist. And then I had an opportunity to do study leave in King George Medical College, Lucknow, where I did my fellowship in epidemiology. So after that, I am working as a field epidemiologist, and I also had the opportunity to lead the mobile epidemic investigating team of the Indian Armed Forces at FMC, from where we had to go at different places all over the country at short notice to investigate different types of outbreaks in different terrains. So that was quite an enriching experience, because we could see firsthand how disease at the population level, how they behave, the dynamics. And after working for 27 years in the armed forces, I took voluntary retirement. I was more interested in academics, and I joined in a medical college in Pune as a professor in community medicine and also in epidemiology. And I headed the department for a few years, and I am now on the verge of my retirement, rather, completing 70 years next month. But the institution has been kind enough to offer me to continue as a professor emeritus in epidemiology. So that's a very great honor, and I'm very indebted to my institution to allow me to continue sharing my experiences and interacting with young people and keeping on my toes. That's in a nutshell.
That is such an inspiring journey. And now let's just move on to our main topic. Can you explain the key components of pandemic preparedness for healthcare systems, and what lessons have we learned from previous pandemic, especially the COVID-19?
It's a good question, actually. I have been, since the past 20 years, I have been dealing in academics. It's just asking how do you prepare for your final exam? You have to study throughout the year. Then only you cannot cram at the last moment. So the pandemic nowadays, the preparedness is that you are neglecting the public health infrastructure. You are not doing your homework. You are not doing when we prepare our students for the final exam, we prepare everyone equitably. We not only prepare the front benchers. They will do well in any case. We also try to prepare the backbenchers. We also try to prepare the slow learners. We try to motivate them, and so that and make them work throughout the year. And unfortunately, the same strategy we are not using in our public health, preparing for the pandemic. It's something like a final exam, preparing for pandemic. If you are well prepared, no pandemic can unsettle you. You will come out with flying color. In fact, there won't be a pandemic. I mean, that's the catch-22 situation. There is a pandemic because you are not preparing for the. If you have been doing things well, there wouldn't be a pandemic. The very fact that you say you're having pandemic is because you are not doing your homework, you are not looking after the backbenchers. That's why they create halla at the last moment. And backbenchers, I mean here the peripheral health centers. You go to the primary health centers. So many states, they are understaffed. They do not have resources. Even if they are staffed, the equipments are not there. The roads are not there. The communication channels are not there. So the patients have to travel long distance, and the government did try to cater by doing Ayushman Bharat by the insurance scheme, but that is also tertiary care centered, hospital centered. They have done that wellness clinics and other things at the peripheral health centers, but that is just reshuffling what is already there. But that was not never adequate. We have so in any case, most of the Ayushman Bharat hospitals are also in the cities, so in the rural areas, and a majority of our populations are living in rural areas where the facilities are not there. So they fall sick, they take self medication because there are no doctor, they go to quacks. So disease which could have been cured in the early phase or not, they become more serious, and then they come to the hospitals in the cities. And there are a lot of, if you go to Delhi, you just stand in front of AIMS, you will see the pavement full of patients and their relatives. They are coming, and AIMS is supposed to be center of excellence, but it should not be dealing with common illnesses because it should concentrate on difficult cases. Unfortunately, it is not fair to AIMS, it is not fair to the rural people who do not have health facilities. They have to come all the way from other parts of the year. And there is another issue involved. When they come from other parts, if they are diseased, if they are having infectious disease, all through the route they are spreading the disease. So you understand that. And once there is a pandemic, we cry fire, fire. Then we restrict movement. Then we restrict everything. But everything is the we are shutting the horse door or whatever stable door of the horse has bolted. So if the health facilities are equitably distributed, and you don't require a very high tech, because high tech is required for severe disease. If you require so much high technology, that means you have failed in your primary prevention, secondary prevention, and you are only concentrating on tertiary prevention, which again becomes cost intensive both to the society, to the government, and cost intensive to the individual also. Individual, even if the government gives insurance, individual has to forego his occupation, he loses money, opportunity cost. Individual has to spend money for the travel, and then other members are dependent on him. So it's all a chain of events, and many people fall below the poverty line. And this is actually a ongoing pandemic in our country. If you see, the poor people are facing disease, they are facing, yeah. So this is what.
Yes. So I think again the holistic approach also would work. Everybody will have to work a little bit so that it can be avoided in future.
Yes, holistic approach, and there are other forces which also have to be addressed, like the marketing of food, uh, sugar, soft drinks, fast food, then this ultra processed food. So these are penetrating. You go to the rural areas, every corner you will find all this Maggie and processed foods and Thumbs Up and Coca-Cola, and people think that these are very good, and particularly whereas those who are affluent and literate, they are going to the gym, they are going to, and the poor people, the obesity is rising among unhealthy habits are rising. So long years ago, Marie Antoinette said that if you don't have bread, eat cake. The French queen. So now I think people are following it in spirit. They are eating cake instead of bread. So that is unhealthy, and the unfortunately India has both parts, both ends of the malnutrition. uh, One is the undernutrition. We have the highest rate of undernutrition in the world, under 5 undernutrition. And now we are picking up in obesity also. The childhood undernutrition is related to adult obesity also because of genetic factors. And due to there is a hypothesis known as Barker hypothesis that early childhood malnutrition and early intrauterine growth retardation, the small for low birth weight child born and or under 5 undernutrition, when these grow up as adults, they are more prone to central obesity because they cannot handle the metabolism of carbohydrates. So they put on weight, and Indians are already they have the central obesity compared to the Caucasians. They don't. Their obesity is more, fat distribution is even all over the body, or fat distribution, and we are a decade earlier prone to insulin resistance. We are prone to diabetes. We are prone to coronary artery disease a decade earlier because of this. It starts in the childhood. I mean, so these are the pandemics already we are facing, but they are not creating sensation because these are insidious and slow, and people do not directly link. And in case these handicaps, I would say these comorbidities, because we will have more diabetics in the country. We already have. We are known as the diabetes capital of the world. We will have more people with hypertension in the world. And we have seen in COVID, as you said, what lessons the COVID 19 taught us. COVID 19 taught us that people with comorbidities are vulnerable. Majority of hospitalization deaths occur with 3 or 4 comorbidities. People who healthy, the infection fatality rate was less than 0.001, almost negligible, just like any virus. So I used to teach earlier that this lifestyle, exercise, and healthy food is good to prevent non-communicable disease. Now I tell that it is important to prevent communicable disease also, because if you are unhealthy, you are more vulnerable to communicable disease. So it will kill you within a week, whereas non-communicable disease will kill you in 20 years. You indulge in 20 years, but suddenly a pandemic like COVID comes and you are unhealthy, so you succumb to it. So if you, so it's the preparation for the next pandemic is not only government or in fact government doesn't do much. In fact, I mean, but it has to be done. We can't depend on the government because it is. I'm not saying it doesn't do much. I'm saying even if it tries to do much, it can't do much, and it will mess it up further. It will become too restrictive. It doesn't work at all. And at least if you are healthy, you don't require the government to prevent you from disease. If you are healthy, your pandemic will not affect you because your body has got the natural capacity to fight pandemics.
Yes, that is rightly said. So, health is the key for everything. Now, coming to the next one, early detection and surveillance are often touted as crucial in controlling the spread of infectious disease. So, what systems and technology should healthcare facilities implement to enhance early detection?
Exactly, everything is interlinked. You see, you don't have to use any go an extra mile if you have got a good public health infrastructure. As I said, right? We are on paper. Right, in at the time of independence, the Bhore committee had made a map for roadmap for India, right? The sub center in the primary health centers. At the primary health center, the first contact medical officer is there and his staff. Then the community health center, district hospitals, and then the tertiary care centers in the big cities. So if you have right from the village level at the sub-center level, and then at the village level is the ASA workers. So they are supposed to be monitoring the health. And up the chain, they are sending the report. So if the manpower and human resources are there throughout, they can report any, yeah, it itself becomes an early warning system. But unfortunately, in many parts of the country, those people are not there in the primary health center. Sometimes doctors are not there. They are doing private practice somewhere else and they are drawing salary. This is a ground situation. Then, of course, there about 20 years back, or perhaps more than 20 years back, there was a integrated disease surveillance system was launched, IDSP. That was supposed to use the your network from all these health centers and all the disease to be reported and centrally available in the public domain. Unfortunately, we don't have the working of it very smooth as yet. As one lesson from COVID, which could have been, which we should learn or could have been learned, is that during COVID times we were getting real-time data on the number of cases, number of deaths, each country. I mean, almost 200, 190 countries we were getting it. And how if overnight it was launched and it was working? That means if they want it to work, it works. And they perhaps wanted it to work. What is the motive? I don't know. I mean, there may be some other motive. And I was trying, like I am down with dengue for the past week, and I was trying to look up data sometime back. Let us see what is the data of dengue. The data of dengue has not been updated for the past 6 months. Sometime back I saw. So that we have got a dengue, we are having and it comes in the newspapers. The Pune is dealing with dengue. Bangalore is dealing with dengue. People are going plummeting. The platelet count is plummeting. You see, and we do monitor our platelet count. In fact, my daughter-in-law in Bangalore, she had a low platelet. She had to be admitted. Luckily, the platelet came up. But that is not the way forward, no? Because the poor people, the housekeeper in my block, she lost her 18-year-old girl to dengue last month because they can't afford to take them to hospital to monitor and rare cases. So these, if nobody is counting the deaths in dengue, I mean, in COVID, so much scare was there. Schools were closed and other things were closed, and every day a more. If you start counting the dengue deaths in children and other things, and you will find that we are having bigger already a pandemic bigger than COVID on our hands. Why nobody is doing that? Because this is affecting the countries like Asia and Africa and other. Nobody is bothered. Neglected tropical diseases, and any minor thing for them it may be a major thing. The respiratory illnesses, the Western countries, because they don't have these problems of dengue now. Zika has also come up in a big way in Pune, and chikungunya also is there, and combination circulating. These things they are not dealing there. And anything respiratory, they are going all the way. So, but whatever it is, now we should ask why pandemic way, what you are doing, why you are not collecting the data of the conditions which are we are already having, like dengue and other diseases, and even say tuberculosis. We are having every day 1,400 people die from tuberculosis in our country. And if you just check up for the past 3 months, there is a short supply of tuberculosis drugs. Who is going to answer that? Why we don't have tuberculosis drugs? Why we could mobilize 350,000 crore rupees for a vaccine if we want to, but why we cannot mobilize the amount for a tuberculosis drugs? And tuberculosis, poor people, I personally know, they do not get the drugs, they drop out of treatment. They have to work. And once they drop out of treatment, they develop multi-drug resistance tuberculosis. And multi-drug resistance tuberculosis, they can transmit to you or me also. In the COVID, there was this slogan that no one is safe till everyone is safe, everybody is. So tuberculosis, it holds more true. I mean, if the poor person doesn't get tuberculosis treatment, he or she develops a drug resistance strain, and that strain he or she can transmit to me or you also. So that holds good for tuberculosis. So we don't have all this. Then typhoid also is a major issue in a country. Water supply, sanitation is a major issue. So we don't have to wait for the pandemic. We are already having so many pandemics on our hands. I don't know how you are going to define a pandemic. I mean, it's a pandemic.
Right, and also I think the during COVID everybody was so much aware. Now the awareness has also decreased, like taking care of themselves, washing hands, or staying apart. Now everything is not there. It is again back to normal. So I think this also can be prevented by it. We can
No,
continue
but
the
COVID,
precautions we were taking.
COVID, where most of the time all the wrong things were also promoted without evidence, like keeping 6 feet away. There was no evidence. Even the great Anthony Fauci is admitting now in Senate that there was no evidence of 6 feet distance. So these are things which again people are losing trust in the government and organization like the WHO. They are losing trust in the experts. If they keep saying things like this, they will have a tough time in future pandemics. Nobody will listen to them because they had failed us in many ways during the past pandemic. And again, as I said, India and countries like Asia, Africa, we have our own disease pattern. We have got our own disease burden. So we should be deciding our own strategy, our own priorities, and our experts should be dictating the strategy. We should not be listening to someone sitting in Switzerland or someone sitting in New York and giving guidelines, and the whole world is following. It doesn't work that way. Each country is different. We have a high density population, or age profile or demographics are different, or ethnicity is different, or diet is different, or culture is different. So that's why, like, one of the issue by which is being promoted is the pandemic treaty, and all the countries are almost on the verge of signing the global pandemic treaty and the amendments to the international health regulation. This treaty, according to me, is not the correct way. Treaty is not the way to. It's a something because treaty, once it is signed, there would be only WHO will giving the guideline, and that will apply to all countries, irrespective of local country. And we saw in COVID, it failed in COVID. It doesn't work because each COVID behaved differently in different countries. So this treaty would be disastrous for pandemics. It may violate human rights. It may not work. And treaty is reminiscent of war and colonialism, where the colonial rulers used to sign treaties. So treaty is something to. It's not a scientific. It's not a scientific. It should be, and the provisions are quite unscientific in the treaty. One of the provision is that they would be censorship. There would be no. They don't know. They can't define what is misinformation. Anyone who doesn't agree with the official narrative is spreading misinformation. I mean, if a scientist in the COVID-19 also, reputed scientists with great track records, great histories, even scientists from Stanford, Harvard, and Oxford, they were also deplatformed as fringe epidemiologists. So this is not the way science progresses. And in the future pandemics, if you ask me, the scientists should lead strategy, not the uh, politicians, bureaucrats, because what's happening in this treaty and other, the bureaucrats take over, and that is not the way to deal with pandemics.
Yes, rightly said. And also the one point that you know noted that each country has different kind of disease. So it should depend on the country
Yeah.
about the awareness they should spread. Now coming to the next question, we know that infection control in healthcare setting is paramount during the pandemic. So what are the best practices that facilities should adopt to ensure safety and reduce transmission?
Infection control, all hospitals have got their own infection control committees, And besides that, there should be judicious use of antibiotics, because another issue is the rise in antimicrobial resistance. So judicious of antibiotics, which is not followed, and that is one. Then crowding is there, particularly in our country, where and visitors. And then of course the training of the healthcare workers in infection control practices, instruments, and the exhaust ventilation and vacuum ventilation, that flue ventilation, particularly, and the wards, the distance between beds. So there are guidelines laid down. This is the and the minimum admissions should be restricted to necessary cases only. If you are, but what I have seen nowadays, there is a lot of other interest which come, because everybody wants to have the beds capacity, because that is one disadvantage of the corporate model. And even not only corporate model, even the, I think their National Medical Commission also, for teaching hospitals, they insist on so many bed occupancy. And so many times the patients are kept in hospital longer than actually required, because they have to maintain the bed occupancy. Whereas that, as you said, what are the benefit of technology? The benefit of technology nowadays is that most procedures can be done in the OPD. Like cataract surgery, you don't need admission. It can be done in the OPD. But by force, you have to admit the cataract patient, because otherwise ophthalmology ward is empty. And the college gets de-recognized that there is no bed occupancy. So if you admit a ophthalmology cataract surgery patient, the chances of infection increases. So these are, I mean, many things are illogical. So they should change the criteria. Ki, okay, these certain surgeries, if you are having higher bed occupancy, means you are not very efficient. So it should be judged by the number of surgeries. In this case, not by the number of beds filled. Similarly, now many of such examples are there, where the more peripheral centers you have, you require less admissions, and less admission are there. Then the now medical colleges are increasing everywhere. The new colleges are opening, so they require all the beds to be filled. So, and that again will increase the hospital infection. Uh, Otherwise, the infection control is already they are laid down. There is nothing, but the authorities, those who are the like National Medical Commission and all, they require a rethink of the rigid regulations, I would say, which says that so many beds, so many for teaching and other things. That teaching can be done in the outdoor also. So that's why I said ki when bureaucrats, it all becomes bureaucratic. When bureaucrats take over, then things do not function efficiently,
Yes,
whether
rightly.
in a pandemic or whether in day-to-day practice.
Yes, rightly said. And I think these practices, if whatever you mentioned, will create a safe environment for both healthcare workers and patients also.
Yeah.
Now, resource allocation becomes a critical issue during a pandemic. So, how should healthcare facilities prioritize resources like ICU beds, ventilators, and PPT, and what strategies can help in managing limited resources effectively?
A very good question, because the COVID pandemic has taught us lessons how not to waste resources. You see, it starts with not only the bed was later, it started with the initial uh, isolating all patients and contact tracing. So this type of thing, when a communicable disease starts from the foci epicenter, if if it can be done efficiently, that you isolate all case and identify all the cases by contact tracing and admit them, and treat them, so that they, or quarantine them, so that the infection doesn't spread further. You have something like, you have firefighter have doused the fire, the fire did not spread. That is one thing. But suppose it has a forest fire, it has spread. then running after a forest fire is a waste of resources, which they did throughout the pandemic. Which that is by forest fire I mean कि once you fail to nip it in the bud, the infection has spread from China to Chandni Chowk. I mean, in spite of your best efforts, it spread from China to Chandni Chowk. That shows it did not work. And still, you continued the contact tracing, quarantine, sealing of houses and sealing of blocks. So, this is a waste of resources. So, and then at the same time, resources could have been preserved by using the evidence as it evolved. Early in the pandemic, in the first 3 months, it was evolved that the people who were affected were very elderly. Like the maximum mortality in Italy, where the panic started, was the average age was 80 years in nursing homes who died. It's unfortunate, all right, but the young people were hardly having any impact. It did not have any impact on children, and up to 69 years of age, the infection fatality rate was 0.05%. So there was no logic to catch each year and young people and contact trace them, and asymptomatic also doing RT-PCR and quarantining them or admitting to. So that is created a sort of a panic, and in the second wave it created a medical stampede. I know it because in the first wave in India, we were working in the field doing contact tracing. We did a zero survey also. The people in the slums and tenements were affected, where they were cooped up, and then second wave nothing happened to them. The middle class, they had the highest transmission, and they panicked. Everybody in the with the RT-PCR, they rushed to hospitals, asymptomatic cases. So most of the hospital beds got crowded, and this sort of a stampede. Many genuine patients may not have received the care. Other diseases were neglected. So these is something which, I mean, waste of resources, and the testing kits also. Why test asymptomatic patients? Only test those who are symptomatic. Firstly, only test those who have got a comorbid condition, which they did in the swine flu pandemic. That was in 2009. They did very well. There was no panic. This time, what they did, they went overreach. They kept on chasing people, asymptomatic people. So it created a sort of a anarchy, chaos. So this was a waste of resources, and PP kits and other things, those also were not required for every patient because we knew it was spreading by respiratory. So there is no point in wearing a gown and other things. So there are a lot of things we did not follow the science. We the as I said, the bureaucrats took over. The guidelines were coming from the top. So many people and so the yeah, not being flexible at the local level, what is required. So if you have to take decisions at the level of the patient, you will be more efficient rather than somebody sitting in the armchair at the top is sending instructions.
Yes, effective management and proper
Now what happens, a lot of vested interest also come. They have ordered so many kits, they have ordered so many masks, they have to sell them. They have ordered so many gloves, they have to sell them. I mean, I read about this glove maker in Malaysia who was selling gloves on the footpath. He became a millionaire in a month by selling gloves.
Okay, that was very interesting. So now, before we conclude, I'd like to express my gratitude for your time and knowledge, Dr. Banerjee. And I must say, your contribution to public health are truly commendable. Your expertise is invaluable, and we would love to continue your engagement with us.
Thank you, Hetvi. It was a pleasure. My pleasure. Thank you.
Thank you, same here. And to our listeners, thank you for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, don't hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So, until next time, stay safe and stay informed.